much for the kind introduction. Dr. Svensson was going to moderate, but he has some meeting. So otherwise, I had a disclosure to say that I'm an interventional cardiologist, not a surgeon, and the moderator is my boss, so I have to temper what I'm going to say, but I'm not going to put that disclosure. With that in mind, I have so the first slide, I kept a few slides so that when people come, it is easier. But the aortic valve, in general, is a fascination for me and a lot of people, that it is in the center of the heart. Now we are going to work in the middle of the heart to replace the valve. It is a central valve. People think that it is the strongest valve. It is not, because mitral valve is the strongest valve because it closes in systole. This closes in diastole. But it is very important to the function of the heart because it lets the blood come out, but also has the coronary perfusion. So without the aortic valve, there is no coronary perfusion. So this is a very important part of the thing to remember. I want to put this in perspective that it is the 250 years of United States. So just to put this in light, that aortic valve was known in 1512, before the United States was formed. 150 years it took to identify that the valve gets narrowed. So Leonardo da Vinci said in 1512, he put these curves and says that how the aortic valve looks. 150 years it took before somebody figured out that it can get narrow. And then it took 300 years before Harkin put the first aortic valve replacement. 300 years. So this is 250 years now to the United States. So this is a huge accomplishment that in now 30, I could not even put a year, in 30 years, so in 1989, Anderson came up with the idea that, so Hanning came up with the idea that he is going to put in a pig the aortic valve. So he brought the frames from in his garage, he made this aortic valve and put it in the pig. And then he submitted to European Heart Journal. They rejected it. Then he submitted to a lot of different journals. And then finally, he got it accepted again in European Heart Journal. And so this was published in 1990, 92, I think, as you see there. So this was the first time that anybody replaced an aortic valve in a living animal. Then he could not sell his patent. He could not. So the Stanford Technologies bought the patent in 1993. Heartport acquired, Heartport was, then it was become Heartport. The Heartport was acquired by J&J, but J&J sold the patent of this aortic valve. They didn't acquire everything else, but they said, we don't need this one. So they sold this patent 2 days before to PVT. And PVT is with Alan Cribier, Marty, and Stan, all these guys then formed a company. And just you can realize that in so many years, so like 2 years, they came up with the valve because everything was done. 2 years, they came up with the valve and they implanted. This is Dr. Cribier. He passed away in February of 2024. He was actually going to come and give us grand rounds on 2024 May. He did this aortic valve replacement in this gentleman who is 57-year-old in 2002. The system was developed for transfemoral arterial access. This patient had no arterial access. He had a aortofem bifem bypass or whatever. So he, on the spot, the day before, they decided they are going to do transeptally. So he did it, the TAVR transeptally that day, and patient survived. He died 6 months later from some other comorbidities that he had, but he survived. He had a balloon valvuloplasty and he didn't do well. So after the TAVR, he did well. And there was only one size of the TAVR available, 23 millimeter valve. It was an equine pericardium valve. So this was another very important thing, that the valve was made from equine pericardium, the first valve. Dr. Cribier is a close colleague, friend. And Jean-Claude Laborde, he was another person who did the first core valve. So there is a balloon expandable valve and the self-expanding valve. So the self-expanding valve, the first valve who did it that was done in India actually, and the first in man, and that was done in 2004. Dr. Braunwald had published this paper, as you know, from a long, long time ago in 1968, just close to our date of birth. And if you look at this, He came up with from 12 patients with hemodynamic data and 53 patients with necropsy data, dead people, that if you develop symptoms, you will die from aortic stenosis very, very fast. So he came up with this idea that this is going to happen. When the aortic valve was designed, the question came to FDA that should we do a randomized trial. They knew this, but they said, hey, listen, there are 12 patients. This is not a good study of any kind to say that we should randomize them to nothing versus aortic valve, or we should randomize, we just do a single arm study. So FDA requested to do a study with, I think, crazy people, to do randomized trial of having severe symptomatic aortic stenosis who cannot undergo surgery to have TAVR versus nothing. And we published it in Lancet. This was the first trial, the partner 1B trial. We were the highest enrollers. We did 279 patients total. And in this trial, 179 in each group, control meaning the people who did not have anything done, one patient was alive without AVR at 5 years, one patient. So this is a terrible experiment because we enrolled so many patients and many patients died while waiting for aortic valve replacement therapy. And the treatment arm, 49 patients were alive, and this was 84-year-old patients. And then the editorial says that the reason why somebody wrote you can read it, but so the name will be apparent, but they say that the reason why the control arm people died is because people did aortic valvuloplasty, and this was a detrimental procedure. I responded to it that, it's just ask some clinicians that what really happened, because it is crazy to think that, and it has proven wrong. So now extreme risk, high risk, intermediate risk, and low risk patients, there are several trials, and Dr. Swenson is not here, but he wanted me to let you know that, he was, of course, in the executive committee. Dr. Tuju was. I was younger, in the steering committee, they called it, or the Young Turks committee or something like that. And then he also, at that time, it was very important that there was a transapical group of patients. And so we were doing initially transapical studies also. Then it became to the intermediate risk and then the low risk patients. And in the low risk patients now, the latest paper was published, which was 7-year outcome data. Now 10-year outcome data from the partner 2A will be published very soon. So there is also a 10-year data from both the partner 2A and the intermediate risk patients. So high risk and intermediate risk patients, 10-year data are available now. But again, these are still embargoed, so I will not put it in my presentation. Important thing that has happened with all this different technology is that now the whole thing, TAVR, is available everywhere. So this is a recent paper that shows that if you look at the centers available, you can drive 59 minutes to get a TAVR. You can drive 54 minutes to get a SAVR. So this is available everywhere. This analysis, I didn't do it. It is a next generation so I just put it in perspective that we can see all these things happen in one generation when it took 150 years. This is one of my son's high school project or whatever. So the idea is that what did we do? So we started this is our 20th year of TAVR. So this is also a landmark year, so this is good for 2026. So we started in 2006, the first TAVR, and we did 262 patients until 2012 with no mortality, with 0 30-day mortality. This was unheard of. So we said that let us write it because we had 14 patients that we identified that would have died anywhere else. So these 14 patients, how they survived in Cleveland Clinic is all because of the different kinds of strategies that we use. We put in perspective, we practiced. We said that we will not do if we are truthful that these patients are non-operative candidates, they are not operative candidates, we are not going to operate on them while they are crashing. Because if we operate on them while we have a serious complication, they are going to die. Because we did everything possible to say that they are not operative candidates or very high-risk operative candidates. So we created all the safety networks with the surgical help to say that, we will have some kind of a cardiopulmonary bypass, put them on an ECMO and things like that, but fix them percutaneously. And that worked. And nobody died. So this was amazing. So this is the 30-day mortality, 0.4. I said 0, but it was 1. And as you can see, this vascular complications were high, 10%, stroke were 2%, major bleeding 5.2%. But compared to the more recent times, these were high numbers, but this is 2012. And we did 10 patients in each year, and now in 2012, 92 patients, because the first time the valve became available in 2012 commercially. At the same time, so we published that too to say that if you look at Germany, France, Italy, partner, and Cleveland Clinic data, these were the mortality published. So a lot of people thought that we were making up the numbers, but Dr. Cosgrove and Dr. Lytle told us that when you have the first mortality, please come back and let us review that whether we want to continue with the program or not. So this was with Dr. Roselli, Dr. Swenson, very important thing for all of us to say that we want to make all these patients survive. And this was a tremendous effort on everybody's part. This is how it looked. So we thought it was minimally invasive, but it looked very bloody, large size sheaths. So we went in the one side with the arterial sheath, with a crossover sheath on the other side, and put pacemaker, all these things that you see here. And we used general anesthesia and Swan-Ganz catheter and Foley catheter, and kept patients in the hospital. Where are we today? So we have a large room, beautiful room with wonderful anesthesia support, and but there is absolutely not many people there. And we are using just this much. So in the one groin, small sheets going in the artery, in the same artery access, wrist access for the sentinel, and this is the sentinel device. And then we are deploying the valve with a rapid pacing, as you see here, and check the aortic valve, and then discharge the patient same day in about 25% of times, next day almost everybody. So this is a big change in the last 20 years that we have accomplished. So the change is real, from the sternotomy to the minimally invasive, and if you look at the national data and everything, there is a lot of difference that has happened. What are the most important learning points? So I said that these are the hurdles that we had and we faced, and how we solved it, and where we stand right now. So that's why I put this presentation in this format. So complications-wise, the paravalvular leak was the first one and the most important one for us, because this is the first paper we wrote. This was in 2012. This is the paper that has been cited a lot, because we found that initially we said to everybody that little bit of paravalvular leak is not detrimental, because there were some data to say chronic AI people live 40 years. Bob Bono published some of this kind of literature. So, but this is an acute AR. This is a different kind of a connotation than having a chronic slow AR. So these people were dying. And Dr. Hanna is not here, but one of our cardiologist in Hillcrest, Dr. Hanna's father. He called me one day. He says, Samir, these people are having AI. I can hear the AI, and they are going to die. And what are you trying to do? I said, no. There's a lot of literature. They are not going to die. They'll be fine. So we looked at all these data, and we found that the mortality is 2.5 times more if you have paravalvular leak, moderate or severe. And so why was that? Because we were doing transthoracic echo to determine that what is the size of the valve that we want to put. If the LVOT measured less than 21, we put 23 valve, more than 23, 26 valve. We didn't have 29 valve. So this is what we did. But with Dr. Sean Hagan, we did everybody's CT scan. So we did Cleveland Clinic, we did CT scan, we didn't read it. We didn't know what to do with it. So we measured all these things, but we didn't implement anything. And so this is a kind of a patient that we have all this data, short axis, long axis, this thing, that thing. We finally put a balloon in them, 23 millimeter, and see if the dye goes through. And if the dye went through, then we said, okay, this may need a 26 valve. It didn't. Then we said, okay, we put a 23. So this was a very crude assessment. And this is the, just to put this in perspective, this is the way it worked. So this is the first SAPIEN valve. And you see that we put the valve, checked it in, we had biplane. So we checked it in 2 views. We put the pigtail. We memorized that where the valve should be placed. Then we took out the pigtail. We don't inject any dye. And then we deploy the valve fast. As you can see here, we are deploying valve as fast as possible. So it is a very different way of doing this thing. You know, as you say, it's a porcelain aorta, and we are deploying the valve. And this patient did very well. You know, there's no AR. Now, the moderate to severe AR decreased because we are sizing them right. So the sizing, imaging is the critical part. And we published a lot of literature from here and from elsewhere, but here in particular to say how we measure, what we size, how we put the annular plane right. And now in Cleveland Clinic, this is Cleveland Clinic data on the side, that moderate PVL is less than 2.2%. So this is a very rare thing these days for us to have a patient with a paravalvular leak. And we assess the AR. This is another challenge that most of the people do not do an aortogram. So we always do a biplane aortogram. So we check the valve. Even if it's leaking a little bit, we post-dilate it. We use a slow inflation, and then we recheck it. And then we came up with a lot of different ways, hemodynamic ways, to determine. We published all of these things to say that we can have a AR index, so diastolic pressure of the aorta versus LV, how it increases or decreases, and the dicrotic notch. So dicrotic notch is very interesting, that if the dicrotic notch happens early, that means the aortic valve is closing early, that means patient has more AR. So if the dicrotic notch goes a little bit further, they have less AR. So this is a very important part. So we can measure, we created this index, we call it dicrotic notch index, and then we can determine if they have AR or not and how we can follow them long term. So these are all different hemodynamic measures we decided. So this is the dicrotic notch index. And then we also did the AR assessment in echo every patient. While we are finishing, the echo tech comes to the room, and we do this. We decrease the aliasing velocity to make sure that we are not missing some AR, and we try to assess the AR. So this has helped us tremendously to solve this problem. The second problem was stroke, because this was the idea that the stroke risk, what is the stroke risk? So in the partner 1B, that is the trial where there was no surgical cohort, and partner 1A, which has the surgical cohort, believe it or not, the first 2 trials, stroke was not an endpoint, was not a primary endpoint. So there was no neurological examination. It was self-reported. And so in the partner 1A trial, there was 6.2% stroke risk. This is total stroke risk, but 6.2% stroke risk in TAVR patients and 2.6% stroke risk in surgery patients. So Herzer Schaff wrote an editorial in New England Journal saying that TAVR is not going to last because it is causing a lot of stroke, and appropriately so because it was showing a large difference in the stroke. Subsequently, FDA mandated that we should have stroke as an endpoint, primary endpoint, so that the neurologist examined the patient, and we had all the patients seen by neurologist after TAVR or surgery, whatever the group was. Subsequently, with Dr. Blackstone, so if you look at the TAVR risk of stroke right now, it is about 2.5%. TVT is a registry, which is self-reported registry, reports about half of them. So it is about 1.4% stroke risk in TAVR, which is not small, and I'll explain to you. But the idea is that with Dr. Blackstone, we did a lot of in-depth analysis of all the partner trial to say that what is the major stroke? With surgery, so the TF-TAVR is in blue and surgery is in yellow. And you can see that the major strokes were actually less with TAVR than with surgery. in all the partner trials. So this was, so some people took it as a gold standard, said that, okay, we reached the gold standard and we don't need to decrease the risk of stroke. Patients, when they come to us, they don't think that we are doing a surgery. They think that they are having a cardiac catheterization procedure. So their understanding of stroke, or they say that the stroke risk should be 1 in 1,000, not 1 in 100 or 2 in 100. So this is a very different perception or expectation of the consumer. And I agree with them that, I think if we are doing a minimally invasive procedure, we should aim for the stroke that is that low. So this device came, Sentinel device. I was personally very involved with this. So we did the Sentinel trial. So we did initially the trial. We got an approval from the FDA, even though the trial missed the primary endpoint, because in 99% of the filters, we captured something. So then we did this trial on the left-hand side, this trial. This trial was called a protected TAVR trial. This trial, we randomized 1,500 patients in each group, Sentinel or no Sentinel. And what we found was that, unfortunately, the minor strokes, which was the primary, or all strokes, which was the primary endpoint, was no different, but the disabling strokes were different. Disabling strokes were significantly reduced, but it was a secondary endpoint. So that creates a problem, because then we say that, okay, this is a secondary endpoint, we didn't have a conclusive data. So now in BHF TAVI, this is a trial that was done in London. They randomized 8,000 patients. So this is now a large study. And they found nothing. They found that there was absolutely no difference. So why is that? So if you look at the United States cohort in the protected TAVR, which was, again, a secondary analysis, but if you look at 1,800 patients in the United States, the trial was strongly positive. So trial was strongly positive in the United States, but it was negative in Europe. And there were several reasons, that the way they check the ACT, the way they do these things, the way the people are there. There may be a lot of differences. But again, this was a hypothesis generating, because this was a secondary analysis of the trial. So we said that let us look at combine the data. We had already proposed that when the BHF TAVI is done, we will combine the data. So now we have 10,000 patients, and we have all this data. And people are 80 years of old and typical TAVR patients. If you combine the data, there is no difference in the total strokes, but there is a slight difference in the disabling strokes, 1.3 versus 1.0%. And again, the p-value is not significant with 10,000 patients. Now remember that the TAVR valve was approved with, say, low-risk trial was 1,000-patient trial. So the prime, and it is sold, what, $32,000. Sentinel device is sold at the most for $2,000. And we are doing 10,000 patient trials. So it is going to be impossible to do more trials with this. So we are trying to understand that what is happening. So in the BHF TAVI, only 80% of the patients, 82% of the patients got the filter. 18% of the patients, even though they were randomized to filter, did not get a filter. And it is unclear that why this is happening, because they said that they wanted radial access for other things, whatever the reasons are. So they never put the filter in them. So if they didn't put a filter, they should do a per protocol analysis to say that, okay, at least let us find out the people who had filter, what happened. So we said that at least we will do the per protocol analysis. So if you do the per protocol analysis, it is strongly positive. So if the people got filter, they had less stroke. All strokes were less, and the major strokes were less. So in both the BHF TAVI, protected TAVR, and the combined analysis, if we do per protocol analysis, this was strongly positive. Again, New England Journal published this paper, and they did not put any of this data. So I'm struggling, not struggling, but I'm fighting to say that we will get this published somewhere, to say that, because this is not available. So you will not be able to find this, to say that what was the per protocol analysis. They presented it we tried to present it in the EuroPCR, but again, the slides are not available online. So it is clear that there was a benefit of this device. So we are doing it. If you look at the Cleveland Clinic in 2017, we are using in all patients the Sentinel device since 2017. And we did our own analysis, so 3,000 patients in the protected TAVR, 3,000 patients from Cleveland Clinic, and 1,000 patients without, and 1,800 patients with. And we had 15 strokes, 1.4% versus 0.4% stroke. So you can see our stroke rate is less than others, but still 1.4 versus 0.4. And very importantly, out of 15 patients who had stroke, 4 died, 25% mortality, because they're major strokes. And out of 8 patients who had stroke with Sentinel, nobody died. So this is a very important part also, that it decreases the major strokes and maybe make it smaller strokes because we don't cover the left vertebral. These are our outcomes at the main campus, and you'll see this slide many times. But the stroke, if you look at it in 4,444 patients, is 0.5%, unheard of. So if you look at TVT registry data, any of the major trials, everywhere, they are in the range of 1.5 to 2.5 currently, and we are at 0.5%. And this is, as you see, with all, these are all patients, alternative access, everything. What are the ongoing trials? There's several ongoing trials, but the whole field is a little bit disrupted because of the fact that the Sentinel BHF TAVI trial was negative. So funding has decreased because a lot of people think that this is a no-win situation. But hopefully, I'm working very hard, and a lot of other people are, to see that we can get some reimbursement. The main reason why it is not commonly used is because there's no reimbursement by Medicare for this device. So we pay from Cleveland Clinic, from our account, to put this device for $2,000. So we lose $2,000 per patient by using this device. But we think it is ethically the right thing to do, so that's why we are doing it. So we said that we want to do a randomized trial so that people are also having late strokes, because after TAVR, 30% of people have atrial fibrillation. In surgery, you do sometimes the atrial fibrillation clipping of the appendage or sewing up the appendage. So we did a trial to randomize people with TAVR with Watchman and TAVR without Watchman. Now this is a very interesting trial because it's a little bit before the time of people thinking like this, because the idea is that these are 2 separate procedures, in the sense that we are doing a transeptal puncture, putting the appendage device, and we are doing TAVR. So there's nothing common between the 2 procedures. So we are doing 2 procedures because the patient is in the cath lab or in the OR. And this was a trial that I designed, and a lot of people argued that is this the right way, but I said this is what patients' expectations are, that you are coming to the OR, take care of whatever I have, and because this is what they are used to when they have open heart surgery. So this may be the new future where people would want angioplasties and TAVR and Watchman and mitral clip at the same time, rather than trying to do it in 4 different procedures. If one is successful and if you think it is appropriate. So we did this study, and what we found was very important, that there was no penalty to do these 2 procedures at the same time. If you look at the TAVR plus left atrial appendage occlusion, they did better, or at least not worse, equal. And all-cause mortality was equal, and strokes were equal, a little bit less, but not more. And the major bleeding, by the way, the major bleeding was a little bit higher numerically. Mainly the reason was that at that time the Watchman required that we have to change them from Eliquis to warfarin. So this is the reason why, because it's an FDA trial, IFU trial, we had to change them to warfarin. So this, I think, was detrimental in the first few months after the procedure. However, very important thing is that in the control arm, we said that people can do whatever they want to do. And 66% of the people were on anticoagulation. 33%, 1/3 of the people on follow-up were not on anticoagulation, because the doctors thought that these old people are too high risk for anticoagulation. So they stopped the anticoagulation, and they didn't put a Watchman. And Dr. Grant Reed just presented this to show that people who did not get Watchman and did not have anticoagulation, they did horribly in this trial. So again, the idea is that we can do combined procedures, and we can do it safely. And these were 21 centers, so this was not 1-center trial. So this 21-center trial. So this can be done routinely. How about the heart block? So the heart block, again, this was another major thing. How do we put a valve? So we didn't know where to put the valve. So we had to define an aortic valve plane. So I went with Dr. Tuju and myself, we went to Vancouver to learn the TAVR, and Dr. Webb was doing the TAVR and putting it in the AP view, and he showed us 4 patients, and he said, do you know, Samir, which patient is going to embolize? So I said, I know that I cannot tell because you are doing it in this crazy view, that we cannot tell which patient is going to embolize. So Dr. Tuju is pushing me. He says, that don't tell him, we will write it. I said, I said, okay, we will write it, but let us just, because people are going to die like this. So we came back and we published that there is an aortic valve plane that you can identify from the CAT scan or from aortography to say that this is the plane on fluoroscopy that you should put the valve in. And this was one of the first papers that we wrote with Paul. Then came a lot of this thing. Of course, we know that the anatomy of surgery, that under the non-coronary cusp, there is there's the AV node, and when the left bundle goes, it goes under the right coronary cusp. And the membranous septum is underneath this, and there are different shapes of the membranous septum. And when we put the TAVR valve, it goes at the nadir of all the cusps, or we try to put it there. So if you say that we put it there, then because of the shape of this membranous septum, the left bundle comes like this, or the AV nodal branch is like this. So it depends on where exactly is the plane in which you are going to put the valve, and what is the relationship to the membranous septum. And then there is an interesting thing with Anderson. We came up with this idea that when the heart forms, there can be a clockwise or counterclockwise rotation. We are analyzing this data. So the idea is that if you know that interatrial septum, if you non-coronary cusp and the left coronary cusp, the commissure is typically well aligned to that. If it rotates counterclockwise and goes there, if the commissure goes there, then the left bundle comes a little bit closer to the right coronary cusp. And if it is like this, it comes a little bit further. So this is embryological study that we did, and is published, I think, in Heart or something, where we came up with this very nice idea that where is the valve. And then in our data, we tried to change our procedure, and now we put the straight flush catheter in the in the non-coronary cusp, and then we align our fluoroscopy in certain ways. And then instead of putting the valve at 3.2 millimeters, we are able to put the valve at 1.5 plus minus 1.6 without increased risk of embolization, without increased anything. And we decrease the pacemaker, new left bundle, from 12 to 5, and pacemaker rate also 13 to 5. So a big difference in the way we implant the valve. So everything we tried to do, we tried to publish to say that this is what we have done. In the country, still, the pacemaker rate is 6%. So the 6% pacemaker rate, that whatever way you cut it, you will find 6% pacemaker rate after TAVR. So all the randomized trials, 6%. Cleveland Clinic, again, from new pacemaker rate is 3.1%. And this is for all valves. This is not just balloon expandable valves. This is for all valves. And this is, again, a lot of people say that we are not 100% accurate, but this is accurate data, because this is not reproduced in other places, because we have a biplane lab. We are very meticulous about where we place the valve. This is a huge help. With Dr. Krishnaswamy, we did this study to say that we pace in the right atrium at the end of because we put a temporary wire. So we pace in the right atrium, and then we check the conduction at the end of the procedure. So if we can conduct at 120 beats, nobody required a pacemaker for heart block. So we said that we can discharge the patient the same day. So this is also a very important paper that Amar wrote. With Khaldoon, we did a prospective study to put a Zio patch before TAVR, at the time of TAVR, after TAVR, to say that how much conduction abnormalities we find. And what we found is that pre-TAVR, post-TAVR, 2 to 3 months post-TAVR, there was no additional benefit of doing these Zio patches to find out that how conduction abnormalities were there, if we can do at the time of procedure what we did. So Right bundle branch block and QRS duration were the most important predictors in this particular trial, also the bradyarrhythmia trial. Vascular complications, huge problem. Eric is here, so we used to Dr. Roselli, and we had a lot of different complications we had because the sheets were large, and we were learning, and we were trying to do these things in a very calcified arteries. Now, we changed it. We said that we are going to do it very simply. So we put a sheath in one groin, and then we put the sheath underneath, just in the same groin. Nobody else does it, by the way. So this is Cleveland Clinic thing. We designed this. We are doing it. And now we are doing it from 2017 onwards. We love it. And we have, and so patient thinks that one groin has been instrumented, not two groins are instrumented. We put this small catheter. This is our standard procedure. And we published it, that it is extremely safe. And at the end of the procedure, if there is a little stenosis, we can just balloon it because we have a sheath right there. So we just put a balloon through the same sheath underneath and balloon it. So this has changed at least our complication rate from vascular complication tremendously. We use 1 per close. Everybody else uses 2 per closes, so we use 1 per close. And then we also published this, that is very safe. If we need, we put an angiosyl at the end. 60% people need an angiosyl. But again, this combination works very well for vascular closure. Coronary occlusion, again, it happens in 0.6% of patients. Valve-in-valve, maybe 2% of patients. This was our 8th patient in Cleveland Clinic. We deployed the valve, as you see, TEE, Swan-Ganz catheter. We deployed the valve, and you see after deployment of the valve, heart is trying to not come back. A person standing next to me from Edwards said that, Samir, we need an autopsy on this patient because this happened once before in France. And we don't know why this happens, that the left main may have closed or something. So. But we had planned it. We had known this patient. We planned it that we are going to poke. That time we didn't have electro surgery kind of procedures. So we put the guiding catheter very fast. We put the patient on tandem heart because that time we decided that we were going to put them on tandem heart. We had planned it so that we don't need a large, it is the same, but the idea was to put them on tandem heart. So we put the patient on tandem heart, and we poked the leaflet with the wrong end of the wire, the stiff end of the wire, and created a hole, and then we stented it. So we are doing CPR, left main is closed, and we could stent it. It was a short left main. She was an 84-year-old lady, Italian lady, very nice. She survived 5 years with a normal LV. We did a CAT scan afterwards, and then we published that this is what happened. We had a CAT scan before, believe it or not, but we didn't know how to analyze it. So there was a huge chunk. So the left main came right from the middle of the sinus. Sometimes it comes posteriorly, then the leaflet is smaller. This was right in the middle, and there was a big chunk of calcium, and it was low, and the sinus were small. Everything was perfect to close it. So, and we could see that it closed because of this with a very severely calcified artery. So we published that. This was one of the first papers to say that this is why the left main closes. Now what do we do? So then we came up with this idea that we can protect the left main with a chimney stent. So this is the chimney stent that you put another stent next to it. Doesn't work. So then we came up with this idea that we can do the basilica. So this is a good idea that. So we perforate this leaflet, and one of this thing has a voice in it. We perforate the leaflet, and then we snare the valve, then we cut the leaflet right here. We are cutting the leaflet, and then we're putting the new valve. And then you see the left main is low behind the artery, but it's still widely patent. Then we came up with a new idea to say that now we are going to puncture the leaflet and put it inside the leaflet, the valve. So this is what we call a cleave procedure. Cleave procedure is from Cleveland, so we said that this is a cleave procedure. So we are going to now, so what we did is we took the leaflet. This was a patient with a core valve with Jehovah's Witness. So we punctured the leaflet, and then we will put the valve here, and then we expand. So this leaflet is detached from the valve. and the patient did tremendous. And the procedural steps are very simple because now we don't need to snare or anything. We just poke the leaflet, puncture it, and then we balloon it and put a new valve. Dr. Krishnaswamy did a very nice, elegant study in vitro where we took all these different types of valves and we poked them, and then we put a new valve and demonstrated that how the leaflet is avulsed from different valves. So again, this is something that is not commonly done, and I'm not suggesting that everybody starts doing it, but we have been doing it very routinely in several patients with good success. And we are doing it also for the mitral valve, by the way, for the anterior mitral leaflet. Economics. Economics is a trouble because if you look at the Medicare, how they designed this thing. So Medicare was paying $55,000 to $65,000 for AVR. So when the cost analysis came available, the device cost for the surgical valve was $5,000, hospital cost was $50,000. Device cost, because the hospital cost was $20,000, Edwards says that why should Medicare pay less? Medicare should pay the same amount that they were paying for the entire AVR procedure. So Edwards and Medtronic, both, because they are conflicted, because they pay each other, they said that they want to have the same reimbursement for the TAVR, and since hospital gets $20,000, they want to have $32,000. So they took $32,000 out of the $50,000. Now, remember the hospital cost for the OR is a fixed cost, so it is not. And we are still doing 3 or at the most 4 TAVRs a day, and you can do 2 surgeries a day. So if you are doing 2 surgeries a day, you make, so the cost of the hospital is not that different. So if you look at the margin is very high for surgery because the hospital cost is less. And the hospital cost is less compared to surgery, but not that less. So instead of 25 to 35,000, it is 15 to 20,000. So your margin is very little or non-existent. So this is a big challenge for us and for everybody else to say that when we are doing TAVR, we need to maintain our surgical volumes so that we can have an economically viable option for the progress. And durability. So the durability is the last piece. So if you look at this particular data, with Dr. Blackstone, we did this to say that there are 11 definitions of durability by FDA. This is not designed by me. FDA came up with 11 definitions for bioprosthetic valve approval. And these were all these different 11 definitions. And the durability of the valve, of the surgical valve, was all over the place. So if you take it different ages, and this is FDA approved data. So we got all this data of 220 papers and we've plotted it all. And then we came up with the conclusion that, for this we need a rigorous data with one definition, one idea, one close follow-up. Otherwise, it's impossible to understand what this durability means. So is it similar to SAVR, and is the treatment similar when it fails? So this is the PARTNER 3 data, 1,000 patients, as I said, randomized, 7-year data now available. A primary endpoint does include the rehospitalization. So 37 versus 34%, similar, statistically no different at 7 years. Death, stroke, and rehospitalization. If you look at freedom from death, it is 65% versus 62.8%, 7 years. Statistically no different. All-cause death here, 0.3, p-value, statistically not different. This is all-cause death in all these patients. And if you look at the restricted mean survival time, there's a 15 days difference positive for SAVR, meaning that you live 15 more days in 7 years' time. If you look at the mean gradient is no different, exactly the same, as you can see there at 7 years. Important clinical difference, the valve thrombosis risk was higher with TAVR because the native valve is still there, 2.8% versus 0.5%, still not statistically significant. New onset atrial fibrillation obviously is higher with surgery, 17% versus 43%. Otherwise, everything else was not. If you look at the other low-risk randomized trial other than PARTNER, there are several of them. We did a meta-analysis. Again, very similar data, all-cause death similar, stroke similar, death and stroke similar. And we concluded that these are these are all randomized trials. So we said that, again, long-term data is required. As I said, at STS, 10-year data for the partner 2A will be available. Redo TAVR is another important part, that we can put a valve in TAVR or not, and what is the risk of putting a valve in TAVR. Again, cutting the leaflet, modifying the leaflet, all these things are important. We published it from the TVT registry in Lancet, that if you look at the redo TAVR versus first TAVR, outcomes are very similar. So we can do redo TAVR with a very little increased gradient. Now, we are extremely careful about putting the first valve for lifetime management to say that surgery is the right choice. If the annulus is small, we can enlarge the annulus, put a new valve, and then do the second valve. Bicuspid aortic valve and asymptomatic AS are the new areas and new valves, and I'll finish in less than 5 minutes. So the early TAVR is the study that is a little bit controversial in my opinion. So people were asymptomatic with severe AS, not blinded. So this is a challenge. So patient comes to you, say that, okay, I have severe AS, but I'm going to randomize you to the medical therapy, and we will watch you for symptoms. So obviously, they are going to come back at some point because now they're worried that they have valve. And if you put an endpoint to say that when you do a TAVR in them, then that's an endpoint, then the crossover endpoint is a little fishy endpoint in my mind. So this is what happened, that all the patients, the trial is positive, published in New England Journal. But the main outcome difference is not from death or anything else. The stroke somehow was different, but it was late stroke. The main difference was from the fact that they were rehospitalized for TAVR within 3 months. And again, this is an important challenge for the placebo-controlled trials or whatever controlled trials without sham. So this is where I don't know how to do these things. This is impossible with TAVR. But this is what is the challenge. Bicuspid aortic valve, as you know, that comes in different forms. Now, there is an interest. So the bicuspid aortic valve, there is a comparison of this thing, but these are not real bicuspid aortic valves. Most of them are of the small fusion of the cusps like this, but not real bicuspid valve that are treated. So this group are treated, and some of these groups are treated with TAVR high-risk patients. If the high-risk patients are treated, then their outcomes are similar. We published this from the Medicare database. However, when we looked at the challenges, this is very clear that we need, if we are going to do this, we need randomized data. So currently, we are not suggesting people to have bicuspid aortic valve, young people to have TAVR. Aortopathy included or not, we are saying that surgery may be the best option. But now there are 4 trials. So the Notion 2 trial was a small trial, so I'm not going to talk about this. But the Navigate, Believers, and Young TAVR are the 3 trials that are in planning. The Believers trial just got recently funded by PCORI grant. So this is all-comers trial for bicuspid aortic valve to be randomized to surgery versus TAVR. So of course, the patients have to be vetted that they can have TAVR, because if the raphe is very calcified, obviously it is difficult to do the TAVR. What are the new aortic valves? So the most important new aortic valve, this is again Cleveland Clinic connection with us. It is called a Siegel valve. This is Dr. Jay Yadav designed this valve, and Mr. Siegel was our patient. This is very close to our heart. So this valve is made from this new alloy. So the new, instead of cobalt, chromium, and nickel, this new alloy, rhenium. Rhenium is the name, I didn't write it there, but it is rhenium. This particular alloy is very important because it has a very high tensile strength. So it doesn't recoil. So instead of having 12 links on a stent, you can put 9 links. So when you crimp it, you can crimp it very tight. So it can go through 8 French sheath. So this valve goes through an 8 French sheath instead of currently 14 and 16 French sheath. So this is a huge improvement. Plus, it becomes circular because it's very strong. So it becomes circular. So the durability may be higher. So this trial, we did the first feasibility trial, looked good. So now it is going to the pivotal trial. DuraVar, again, Dr. Krishnaswamy, myself, Rishi, a lot of people involved with development of this valve also. This is a valve which is mainly designed from this particular tissue that was designed, the DuraVar. That this is a company that had a biological system that they put for the skin grafts, and they didn't calcify. So that's how they came up with this tissue. And this valve is also being studied. And it is a unicuspid valve in the sense that it is made from one leaflet. So, and it has a very high laminar flow coming out of the valve. So the durability may be better. So this is the idea of this valve. Sapien X4 is another valve that has a different cover on the side, and you can commissurally align this valve. So this is also a new valve that is being studied. And Jena valve hopefully will be approved very soon. This is for the AR, so it anchors into the sinuses rather than going on the anchoring on the annulus. And we have done several of this, and this is another valve that we are testing now in another trial. Early detection is another important thing that is happening with chest X-ray, ECG, AI, pressure. And with Serge Harv, we did this study where we put this clear view on the people's fingers to say that whether we can detect in the emergency room that you have aortic stenosis or not without even an echo. And we were pretty good at it. We have not yet published it. We will. The sodium fluoride scan is another important thing to say that early calcification we can detect so that we don't have to wait for 10 years to say that the valve is durable or not. We can tell earlier whether the valve is going to die or not. Tissue engineered valves are not happening, but there is a lot of data on that. And echo-wise, we have come up with this, the ET-AT ratio. So how fast the valve opens and how long the valve opens is very important. So different prosthetic valves open very fast and how long they stay open. And this is an important measure to say that, because there is some debate that the balloon expandable valve or sex-expandable valve are better for small annulus. So this is where this thing is. And we also created the NeoSinus washout software. I want to finish with these two slides, that this is our journey. This is the first hour that we did in 2006. Dr. Swenson, Dr. Whitlow, John Webb, Dr. Rodriguez, and all the other people that you recognize, and Bob Savage, yes, from Anastasia. And as you can see, the nurses. We went to the next step where, here Dr. Tuju, Swenson, and myself working, and we are all working together. And it was, the best colleagues, a lot of things. We are now to the next level. So Dr. Yoon is here, Rishi, Grant, Amar. So this is a new era, so young, talented team, new trials. We are doing a lot of improvement. And if you look at our PubMed publications, on the left is 2025 for TAVR and Cleveland Clinic. We are publishing close to 60 papers a year on TAVR. So this is something to keep in mind, that we are academically extremely involved and making this as good as possible. So thank you for your attention. I know that Dr. Swenson said that he was not going to come, so he gave me more time, so that's why I used it. But if you have questions, we can take the questions.
In the era of early TAVR or earlier TAVR or less symptomatic TAVR, etc., how do you advise that we balance the business of valve-in-valve versus TAVR explant? What age group? When do you suggest what we do?
No, I think it's a very good, important question, lifetime management. But the first question is that I'm not sold on the idea that the asymptomatic patients with aortic valve disease should have aortic valve replacement. Because first of all, in our clinical experience, nobody's dying like that, that we follow. So this is complete, I think is little, because, the companies want to make money. So this is why they come up with all these ideas. But I don't think this is real. So that's number one, that be very careful. So I said the NT-proBNP, high sensitivity troponins, gradient, LVH, all these things that you are, calcium score, all these things that you are following, please follow those things before you subject patients to whatever kind of AVR. So that's number one. Second is that depending on the anatomy. So today's decision tree for us has become anatomy first and then the risk. Anatomy is the most important one. So if you say you do a CAT scan, and if you say that the anatomy is excellent for a large surgical valve, such that the coronaries are high and we will be able to put a new valve, and the patient is 70-year-old, of course have surgery. If you have then we look at the risk. If it's very high risk, okay, then we can do TAVR. On the other hand, if you have a very nice annulus, no risk of rupture, a lot of sinus space, coronaries are high, and we can put a large valve, and we'll put a valve in valve 2 times, there is no reason at 75, we say, okay, hey, listen, you can have TAVR. So anatomy has become our primary way to decide rather than the surgical risk. Because this has become, and surgical risk comes second. And TAVR risk is equally important because some people don't understand that TAVR can be risky too. So many times people come up with this idea that, why don't you do TAVR? I said, I will do TAVR, but it's high risk and surgery is low risk. I get very interesting calls from people. They say, Samir, don't chicken out, and they do the TAVR. From a good colleague and friend and a surgeon. So this is what happens. So I'm saying that it is not chickening out because we have excellent options for the patients in Cleveland Clinic. So this is something to keep in mind. And Eric, go ahead.
You've mentioned that early TAVR is a controversial trial. But if you look back in 2019 and 2022, we had the AVATAR and the recovery trials where we randomized early surgery for asymptomatic, forget TAVR, early surgical valve replacement for asymptomatic severe stenosis. And they were truly asymptomatic without positive stress tests. And survival, a good hard endpoint, was better with early surgical aortic valve replacement. So I think that we're still undertreating aortic stenosis. Our patients are still afraid of coming to see us, interventionalists and surgeons. And so we need to continue to learn more about understanding those fine details. Like the stuff we're looking at, trying to understand myocardial fibrosis and other subtle details, I think will help us to be more precise in that decision making. We need to treat more aortic.
No, we will, yeah. Go ahead, Leslie.
Yeah, there's going to be a 10% Medicare cuts for 2026, specifically for TAVR.
Yeah.
What is our?
So we are the highest volume TAVR center in the country. So I didn't want to put these things in this presentation, but we have ways to work with the companies to get a rebate and get a discount and all these things. So our situation wise, the only way we cut the cost is 2 ways. One is to procedural cost. So we have trimmed down everything, workloads, this thing, that thing. Hospital cost, so we discharge the patients early. And the device cost, which is the most important one. But we have negotiated, Amar, myself, we have been negotiating with them. So we are in good place. For us, the Medicare, unfortunately, for Cleveland area, gives less money. This is another crazy thing. They pay more in New York and Los Angeles compared to Cleveland. And we are equally good hospital, and we spend more money on patients.
Samir, great presentation. Thank you. Are you aware of valves made in China or other places, and how do they compare with the Edwards valves, and do they have any penetration into the U.S. market?
Yeah, I'm aware of them. So there is one important valve that is called MyValve. Not MyValve, but its name is MyValve. It is from India, and it is very comparable to Edwards valve. They did a randomized trial in Europe, and they came out equal. And they have different types of sizes of valves. They have not come to the United States because of patent infringement and all these things that they think may be problematic, but it may happen. China has a venous valve, which is very good. China has also balloon expandable valve, which is very good. So, but in United States, to bring the valves, FDA is very strict, as you know. So there is still going to be a few years where there is not enough competition. But in Europe, the same valve that they sell here, they sell for less, $10,000 less in Europe, Edwards. So when the competition is there, they have to adjust. So this is, and now the mitral valve got approved last week, M3. They are going to put the cost to $55,000.
The device.
Device. So this is, of course, we are using 5 or 6 or something, rare situations. But my point is that this is where the money is. The money, when people invest billions of dollars in this, they want billions of dollars. So this is where the challenge is going to be. So your point is right, Leslie, that we have to worry about the financial side of it, but it's tough.
Samir, I know you didn't touch upon the valve thrombosis part because that's, do we know predictors of halt and how to prevent them and management of halt in some of these patients?
No, I'll just finish very quickly. Yes, we do. So I think the few most important things are, at least in our experience. So first, if the valve is placed low, so anatomically, then there is more stasis. So that's a challenge. If valve is not fully expanded, meaning that it is not circular, then there is more halt. Giving them, and if the sinuses are small, then we see, that's why I showed you the one particular study that we did, where we put a neo-sinus washout to say that how the sinus washes out, and that predicts halt. So the idea is that if we see any of this, we give them 3 months of apixaban with aspirin or without aspirin, most commonly without. And then if they have recurrence, the gradient increases. If the gradient increase, then we always do a CAT scan, as you know. And if they have halt, then we give them 3 to 6 months of anticoagulation with or without aspirin, and then repeat the study after stopping the anticoagulation.
Should we routinely do halt CTs for like 3 months after TAVR?
We tried that in partner trial. Routine CT was recommended by the FDA. What happened is that many people develop halt, then they resolve without knowing, and there was no consequence of what we found on the halt, so it's not recommended anymore.